One of the most common things I hear from patients is, "Doctor, I've already had a hysterectomy, how can I still have endometriosis?" It's a myth that removing the uterus somehow magically cures endo. In reality, hysterectomy only takes out the uterus, and endometriosis by definition exists outside of it. So if those lesions aren't found and removed during surgery, they'll still be in there. And in some cases, the pain and symptoms can be just as bad or even worse than before. Hi, I'm Dr. Abhishek Mangeshikar, robotic excision surgeon and endometriosis specialist. In this video, I'm going to break down why endometriosis can still be a problem after hysterectomy, the symptoms and silent organ damage to watch out for, why these cases are often so missed, how we diagnose residual disease, and the treatment options that truly work. By the end, you'll have a clear understanding of what's really happening in your body and why a hysterectomy is not the final chapter for many women with endometriosis. Let's start with the root misunderstanding. For decades, patients have been told, and many doctors have believed, that hysterectomy is the cure for pelvic pain. The logic is, if the uterus is the source of the pain, take it out and the problem is solved. But endometriosis is not just uterine disease. It's a disease of tissue similar to the uterine lining growing outside the uterus. It can be found on the ovaries, the bowel, the bladder, the pelvic side walls, the parametrium, even the diaphragm or lungs. So removing the uterus addresses adenomyosis, fibroids or bleeding disorders, but it does nothing to the endometriosis lesion sitting outside the uterus. If your surgeon's focus during hysterectomy was only on removing the uterus and not on systematically exploring and excising these other areas, then the endometriosis will still be there, silently continuing its damage. And if your ovaries were left behind, the estrogen they produce can continue to stimulate those lesions. That's why many patients notice their pain still follows a monthly cycle, even without a uterus. In fact, even without ovaries, the lesions themselves can produce their own estrogen, which can still exacerbate symptoms. After hysterectomy, symptoms can overlap with what pain you felt before. Deep pelvic pain, pain with bowel movements, urinary urgency or pain during urination, pain with intercourse, lower back pain radiating into the thighs or legs. But there are also some subtle signs. Cyclical bloating, constipation or even diarrhea, even without a period. Pain that flares at predictable times of the month. New urinary symptoms like slower stream or flank pain may suggest ureteric involvement. And here's the key. If your ovaries are intact, your body is still hormonally cycling, which means your endometriosis is still hormonally active too. This isn't just about pain. Residual endometriosis can cause real organ damage. Ureters, blockage of these can lead to hydronephrosis and kidney failure. Many patients lose a kidney silently without realizing until it's too late. In the bowel, lesions can cause strictures, narrowing of the intestine and leading to pain, bloating or even bowel obstruction. Involvement of the nerves, where deep disease can entrap pelvic nerves, causing chronic neuropathic pain, bladder dysfunction, and in extreme cases, neurological emergencies like a foot drop. That's why dismissing post-hysterectomy pain as scar tissue or normal recovery can be dangerous. Why does this get missed so often? There are two main reasons. One, surgical training. The way most hysterectomies are taught in training is sometimes jokingly called the hug and pray technique, where you hug the uterus closely and you pray you don't injure anything else. That works if the goal is to simply remove the uterus safely, but it will never work for endometriosis. Endometriosis requires a surgical mindset of oncology, where you don't cut through the disease, you go around it and you keep dissecting until you reach healthy tissue. Anything less leaves disease behind. Number two is the way lesions look. Endometriosis isn't always the classic black spots you see in textbooks. Lesions can be clear, white, fibrotic, or buried under scar tissue. Without specialized training, these are very easy to miss. Number three is limited exploration. In many hysterectomies, the parametrium isn't dissected, the bowel isn't mobilized, and the diaphragm isn't inspected, which means disease outside the uterus often remains untouched. How we diagnose residual endometriosis. If you're still having symptoms after hysterectomy, here's how we work it up. History and symptom mapping. We go through your pain cycle in detail. When, where, and what triggers it and how it responds. Next step is high quality imaging. A standard pelvic ultrasound is not enough. We use an MRI with endometriosis protocol, targeted high resolution ultrasound to map the posterior compartment, a CT urography if ureter involvement is suspected to rule out any kidney damage. Then step 3 is functional assessment. Kidney function tests, bladder studies or bowel imaging if symptoms point in those directions. Step 4, surgical confirmation. Sometimes when symptoms and imaging line up strongly, the only way to truly confirm and treat is to perform another surgery, but this time with the goal of mapping and excising every single lesion. Medical suppression or hormonal therapies can reduce pain temporarily, but it does not remove lesions. The only way to achieve lasting relief is complete excision surgery, even if you've already had a hysterectomy. When we plan re-exploration surgery, we consider post-hysterectomy anatomy and scar tissue, risk of adhesions from the previous surgery, the possibility of hidden disease in areas not checked before. Robotic excision is particularly powerful in this setting because of magnified 3D vision, wristed instruments for precise dissection in scarred areas, safer dissection around ureters, bowel and nerves, and in advanced cases a multidisciplinary team may be involved which have urologists for ureteric reconstruction, colorectal surgeons for bowel resection, nerve-sparing approaches if pelvic nerves are involved. This isn't just another hysterectomy, it's a specialized surgery that must be performed by someone deeply trained in advanced excision. The good news, many women regain their quality of life. Once the residual disease is finally removed, recovery depends on how much disease is present and which organs are involved. But in general, hospital stays are usually short, around 2 to 4 days. There is a quick return to light activity within a few weeks and full recovery in 4 to 6 weeks for most cases. And more importantly, kidney function can be preserved if obstructions are caught in time. Bowel symptoms often improve dramatically. Chronic pelvic pain can finally settle after years of being dismissed. If you're still in pain after a hysterectomy, please know this. You're not imagining it and it's not something you just have to live with. Residual endometriosis is real. It can damage organs if left untreated, but with the right expertise, it can be excised and you can get your life back. If you found this video helpful, please like, share and subscribe, not just for this channel, but so more women can understand that hysterectomy is not a cure for endometriosis and that there is a way forward.